fractures in the primary position. There was left eye abduction deficit as you can see later, and there was mild retraction of left eye on reduction, and there was gyropsis of 70 seconds apart with phase turn. So, diagnosis is clear. She was a left eye is retraction alone, classic variety. There was no normal NR activity, and mild to moderate variety or anomalous LR. Before going ahead, just a word about worms. In worms, when the LR is supposed to get supplied during abduction, it is having no supply, and when it is not supposed to get supplied during adduction, it is getting no innervation from medial rectum, thereby having co-contraction of both the muscles. So the goal of management in the case shown was to correct the phase turn and to get rid of the narrowing of alveolar fissure on adduction. So we did a FTT of left eye and first eye for MR. So we did a left eye MR recession of 4 mm. Her phase turn got corrected and she achieved stereopsis of 70 seconds of RD primary position. This case was a similar case with classic variety, mild to moderate dye, but she was different from the first case because she had a larger phase turn and she had a larger amount of esotropia in the primary position than the first patient. But here we did a rather smaller amount of recession of around 4 mm. So the message is that it is not the amount of phase turn or esotropia in primary position which determine the amount of MR recession which we are doing. So now the question is, why only minimal amount of MR recession should be done in worm retraction syndrome? First of all, you are not going to improve adduction. The second thing is you will only worsen adduction, and you can also land up in a more difficult situation of synergistic divergence. Like this child was a case of ESO-DRS, but when we did an MR recession of around 5.5, we landed up in a synergistic divergence. Now you can see that in dextro case, left eye is showing abduction. So it was a case, so he landed up with synergistic divergence. Then we had to do an LR recession of left eye 8 mm, and thereby the thing was corrected. This is the third patient. She was a 16-year-old girl with abduction limitation of right eye. There was, in the primary position, there was 12 to 14 diameters of esotropia. There was no retraction of growth and stereopsis of 70 seconds of arc with phase turn. So she was a case of right eye ESO-DRS. So we did a FDT for right eye MR, which was found to be free. So we did a MR recession of the good eye, that was left eye, about 6 mm, and her phase turn got corrected, and she achieved 70 seconds of stereopsis in primary position. So now the question is, why good eye can be operated? What is the rationale behind it? So when the good eye is operated, the MR is recessed, that the fixation units of the good eye will give the extra stimulus to the medial rectus. Now medial rectus, by the Seligman's law, LR will be inhibited. The good eye LR will be inhibited, and by Lorentz law, it will give less supply to the medial rectus. Now when the medial rectus is getting lesser supply, the anomalous LR tone which is going to the lateral rectus of the DRS eye will be inhibited. So thereby the anomalous LR tone in totality it will be decreased. But always remember that MR of the good eye should be recessed only in the case when in the DRS eye LR is dead. But if you do MR recession of good eye, in case when there is abduction of the DRS eye, that is lateral rectus is abducting, then you will land up in exodeviation. So this is the comparison of pre-op and post-op photograph of the same patient. This was another patient. She had a right-sided phase turn. She had esotropia of around 20 prisms after primary lesions. She had a right eye retraction in primary position which was increasing on adduction. There was upshoot of right eye on ego elevation, and she had 70 seconds of arc with phase turn. And she had also inferior overaction which was confirmed on vulnus extortion. So the diagnosis was right eye ESO-DRS upshoot with inferior overaction with ESO. So she was a classic variety, moderate to severe ESO-DRS. So the goal of management in this case was to correct phase turn, to get rid of retraction of globe and narrowing of alveolar fissure on adduction, and also to get rid of upshoot and downshoot. So what we did over here, we did a differential recession of medial rectus and lateral rectus. MR recession of around 4 mm and LR recession of 7.5. with wide splitting, and also the right inferiorly modified ENN. We should always remember that we should never resect in case of PLS. This was a comparison of pre-op and post-op photograph. See that there is improvement in the retraction where the upshoot has decreased as a patient was quite happy. Now, what are the things we must assess before taking a case of PRS post-surgery? The first of matter is we should check for the normal LR. That can be clinically be checked by limitation of adduction. And how much is the anomalous LR? That can be checked by limitation of adduction. There's retraction of globe, how much is the retraction of globe in primary, adduction and abduction, and the force degeneration test. Now we should also check for how much is the face turn, upshoot, downshoot. Everything should always be checked for MR and LR to look for the contracture of muscle in iso and exotibialis. And balancing of the force is very important, especially in children. We can't do adjustable, you can adjust on table, and in cooperative adults, you can of course do adjustable. This was
let's stop short here. So basically ESO-DRS can be presenting in various forms. Each type of ESO-Duane retraction syndrome is not the same. So you cannot apply the same regime of surgery. As you have seen, if you think that 4.5 mm should be good enough for the ESO deviation which was for 30 prisms and that was done, you had a synergistic divergence. Is it clear for all of you why that happened? Because there was a co-contraction. You have weakened the medial rectus, the lateral rectus is now free to act and it causes exodeviation much more. In fact, all cases of ESO-DRS, if you look carefully, there will always be an exo coming in adduction. Because it's a true Duane retraction syndrome, this will always happen. There is a co-contraction. There is a lateral rectus working during adduction. You have weakened the medial rectus, then the lateral rectus alone acts or is having an edge, so it will cause an exo in adduction edge. But we are limiting it only to the point that it is acceptable and not cause more than exo that can be fused. Okay? So this is something which we need to understand. It's not like any other ESO deviation that we will be happy to do just an MR recession and be happy. It will create a problem of an exo deviation. So you might have to balance if there is a co-contraction which is more than normal or more than the desirable that you want. You might even have to do an LR, lateral rectus recession, maybe along with a Y split if there is a severe co-contraction. So as she has said, there are variable things that you will have to see. Is it normal LR tone or there is an abnormal LR tone, lateral rectus tone? And thirdly, how much is the co-contraction? These are the three variables. And fourth is on table, how much is the FDT? So there is a variation of the tightness of the medial rectus that you will see. If suppose you find the FDT is free, and in that case, if there is in such a situation, you may not do a medial rectus recession at all. Then you may do, for the ESO correction, the medial rectus on the normal side. It may be more effective to do it. Okay? Because it will correct the ESO deviation and it will also reverse the process of anomalous innervation testing. But in ESO-DRS, we are not able to tackle the problem still. The real problem is anomalous innervation of the LR, lateral rectus. But if you do a lateral rectus, and in the presence of a tight FDT of the MR, you have to do a medial rectus also, then you have already tied your hand that you can never do a vertical rectus transpositioning because the risk of anterior segment is keen. But ideally for a DRS, as we are now learning, the basic correction would be to isolate the lateral rectus, which is the basic problem. The basic problem is anomalous innervation to the LR. So now we move on to the ortho and the exo-DRS to understand the DRS problem in little more detail.
She was a case of right eye iso-ortho-DRS. Clinically she looked like ortho, but on PVCT there was small amount of iso which was coming around 10 prism diameter, but there was some normal LR activity. As you can see that there is only -1 LR retraction deficit, and there was retraction of the right eye on adduction. So what we did over here, we did a differential MR and LR recession. MR recession of 5.5 and LR recession of 10 mm with Y split. And she achieved both the improvement in retraction of globe as well as in downshoot improvement. This was the case of exo-DRS, left eye exo-DRS. He had an exotropia of around 15 degrees in primary position, and there was retraction of globe on adduction, and also there was downshoot. So what we chose to do was LR periosity with the FBT which was tied for LR. we fixed the lateral rectus to the periosteum, and we did a partial vertical recti transposition with a cross action on an adjustable basis. And the patient got his exotropia got corrected, and retraction improved, and downfall also improved. This was another patient. She had right face turn and an exotropia of around 15 degrees. There was -3 adduction deficit, as you can see over here, and there was also upshoot and -1 adduction deficit, and there was a reduction of left eye on textbook base. So we did supramaximal. This is another form of another kind of tackling of the exo-DRS. Normally, so then we refer to the supramaximal recession rather than periosteal fixation. So we did a supramaximal recession of around 15 mm with hand act, and we were able to correct both the exotropia and plantar position, as well as retraction of lobe and upshoot. And her face turn also got corrected. Now this is the last case which I will show here. He was a case of again right eye exo-DRS. He had a right face turn. He had an exotropia of around 15 degrees, and right eye had adduction deficit of -1, and there was retraction with upshoot of right eye libo case. And here we did a periosteal fixation along the split APRT, but since the exo was very large, we did a LRR session of liquid as well around 8.5 mm. In this video, I will show how much is the abduction range which we achieved after LR periosteal fixation and partial DRT. You see that the patient right eye is abducting quite nicely after the partial vertical recti. So it is a very good procedure for exo-DRT.